This clinical supervision video overviews a 4-hour CE update produced by Your Choices for qualified supervisors in Florida. The CE is available on CE Broker. In this section of the CE, we will reflect on Objective 4, Review Research of Supervision Models. There will be a quick overview of supervision models based on different methods of therapy, followed by a review of feedback-informed treatment, deliberate practice, and trauma-informed care. We will discuss each of these practice approaches and reflect on how feedback-informed treatment can be fused into clinical supervision. At the close of the session, we will be able to make sense of the fusion of psychotherapy elements in the figure here. We will discuss the therapist's preparation for therapy session, examine how person-centered work becomes the foundation for therapeutic work when we are careful to include the common core elements, and understand how methods and techniques of therapy fit into the clinical work with an awareness of how trauma-informed care principles will improve practice, especially during this time of the pandemic and post-COVID sequelae experienced by clients.
Objective number 4. Review research of supervision models. The developmental models include the integrative developmental model, based on 3 levels of supervisees development: the novice or entry level, intermediate level or process issues, and advanced or independence and or consulting relationship. This works well with recent graduates. The expanded developmental level focuses on 8 stages of clinician development. The stages include competence, transition to professional training, imitation of experts, conditional autonomy, exploration, integration, individuation, and integrity. Supervision based on attachment theory. Infants' neurobiological attachment patterns continue into adulthood and are present in the supervisor-supervisee relationship. The supervisor tailors supervision to such transfer patterns. Generally, secure attachment outcomes between supervisor and supervisee are useful and important in clinical work. The psychotherapy-based models. The psychodynamic model focuses on client-clinician interactions and transference and parallel process. The person-centered model, where the supervisor is not an expert, but rather focuses on supervisor-supervisee relationship, where the supervisor is not more of an expert than the supervisee. The goal is to develop a warm, welcoming space for the supervisee to share concerns and engage in a collaborative process with the supervisor. Cognitive behavioral model. The supervisor with supervisee learns how their cognitions are affecting their skills and to change their cognitions to improve outcomes. The supervisor works with the supervisee to learn how cognitions are affecting their skills and to change their cognitions to improve outcomes. The family therapy model, used with clinicians that work with families. Clinician includes family of origin and learned behavior to understand how these affect work with clients. Feminist model stresses collaborative relationship between supervisee and supervisor. The goal is to empower the clinician, recognize balance, and discuss multiple perspectives. And the integration models. The discrimination model is tailored to individual training needs of the clinician. Skills are separately reviewed, and supervisor determines whether role is that of teacher, counselor, coach, or consultant. The systems framework to supervision provides a framework for the supervisor to use in supervision that does not adhere to any particular specified model. Solution-oriented model, based on family and narrative therapy using solution-focused techniques, allows for the clinician to arrive at his or her own solution to client problems. Feedback-informed treatment, or the FIT model. The models that we have just viewed have a sense of being stuck in the forest, unable to see the trees, or they were individual models. Together they may offer resources for eclectic application in direct practice strategies. There is so much focus on method in the previous discussion, but not on building practice competencies. The FIT model is focused on client outcomes with client input about the therapeutic experience that is documented in the supervisee's development plan. This evidence-based process includes deliberate practice exercises that take place out of the therapy session. The coach or qualified supervisor views video examples, reviews fit tools, and facilitates practice of targeted stretch goals. When a level of mastery is attained, the supervisee moves to the next stretch goal focused on improving client outcomes. We will spend the remainder of today's work examining the common core factors of therapy, feedback-informed treatment, deliberate practice. Trauma-informed care is a person-centered approach that focuses on the patient's understanding of current experience in the here and now. The experience is often viewed from the lens of earlier life traumatic events, which the client re-experiences in the present. The experience is often viewed from the lens of earlier life traumatic events, which the client re-experiences in response to present events. It is as if the person is in a trance, focused on past experiences and overlapping past perceptions and beliefs onto present experience, which may trigger the cumulative feelings of past traumatic experiences. However, the current incident may be unrelated to the previous traumatic experiences. Trauma-informed care requires a shift out of the trance of the past into the here and now that can be mediated by mindfulness approaches around breathing and other options. In the past, we used to ask, "What is wrong with Marie?" This question sets up a focus on pathological and negative thinking about Marie. The trauma-informed perspective inquires, "What has happened to Marie?" Understanding what happened allows one to realize the abreaction in the present is a call for help and requires stepping back, de-escalating, and locating Marie in the present moment. "What just happened, Marie?" Maybe we can stop for a second, slow down your breathing, become aware of your surroundings, etc. There are many definitions of trauma-informed care. This is one of them. Trauma-informed care is a strengths-based framework that is grounded in an understanding of responsiveness to the impact of trauma. That emphasizes physical, psychological, and emotional safety for both providers, survivors, and thrivers, and that creates opportunities for survivors and thrivers to rebuild a sense of control and empowerment. Additional ideas I want to share about this definition include that trauma-informed care is a person and environment strengths-based approach grounded in a person-centered perspective. This leads to a holistic response that incorporates physical, psychological, emotional, and spiritual safety and healing for thrivers and providers. A sense of empowerment and control that leads to reinterpreting beliefs and understanding of traumatic experiences. Categories of trauma. While there are diagnostic categories for trauma in the DSM-5, there are also subclinical experiences of trauma that do not meet diagnostic criteria for a mental health diagnosis. In addition to traumatic experiences, there are more complex perceptions, beliefs, and responses to trauma that meet criteria for a mental health diagnosis and can lead to responsiveness to psychotherapy and use of appropriate medications. We see here there are 4 categories that apply to people in need of intervention that are associated with the DSM-5. First, acute trauma, or type 1, involves a single overwhelming event. Complex trauma, or type 2, extended exposure to traumatic situations, which may mean living in a war zone or a place that has continuing violence on a day-to-day basis. Crossover trauma, or type 3, is the effects of a single devastating event enough to cause long-lasting experiences for the client. And then vicarious trauma, which has to do with others hearing the trauma of the individual being traumatized by the story. There are many types of trauma that may be experienced by supervisees and their clients. The list of 12 are just a few of the innumerable possibilities. First would be the adverse childhood experiences, which could possibly be one of those ongoing kind of traumatic environments where people experience trauma through domestic violence in an ongoing basis. Then intimate partner violence, which perhaps could be similar to with multiple experiences. Domestic violence, post-traumatic stress disorder, which is a result of maybe one or multiple past events, systemic racism, the Holocaust, genocide, disasters, grief and loss, transfer trauma, which may be the experience of an elderly person moving from home into a nursing home and being traumatized by the adjustment, and then COVID related experiences. So there are many more types of trauma. Those are just a few of examples. Then trauma-informed care principles, which I believe are really an important part of our work these days. There are 6 that I've selected here. This seems to be one of the more popular lists. There are lists with 9 and other numbers, but I believe these 6 seem to be the most common that I found in the literature. I would like to go over these. However, when we move to deliberate practice, we will more specifically apply these principles to psychotherapy practice in that discussion. But first, I would like to list the 6 principles just so that we have an idea of what areas they covered. As we go through this, please pay attention to how integral this is to client-centered treatment. First, there's the sense of safety. Throughout the organization, patients and staff feel physically and psychologically safe. 2, trustworthiness and transparency. Decisions are made with transparency and with the goal of building and maintaining trust. 3, peer support. Individuals with shared experiences are integrated into the organization and viewed as integral to the service delivery. 4, collaboration and mutuality. Power differences between staff and clients among staff are leveled to a support shared decision-making focus. 5, empowerment and choice. Patients and staff strengths are recognized, built on, and validated. This includes belief in resilience and the ability to heal from trauma. And 6, cultural, historical, and gender issues. Biases and stereotypes and historical trauma are recognized and addressed. Next, we will move to a discussion on feedback-informed treatment. Feedback-informed treatment, or FIT, and deliberate practice, highlighted in this workshop, comes from the work of Scott Miller, Daryl Chow, Tony Rossmanier, Rodney Goodyear, and Bruce Wampold. I'm not affiliated with these individuals financially and have no conflicts of interest associated with them or their practice. I have completed a deliberate practice workshop presented by Scott Miller and Daryl Chow. There are several others working on the development of deliberate practice, and there are many training programs to assist in further development of these practice approaches and skills. FIT includes the use of client feedback through the Session Rating Scale, or SRS, that measures the quality of therapeutic relationship, and the Outcome Rating Scale, or ORS, that measures the effectiveness of therapy or well-being of clients in daily life. In addition, supervisees record videos of sessions with clients to work on with their supervisors as well. These FIT tools are an essential component of deliberate practice. As one begins work with supervisees, it is important to establish a baseline of current skills levels. Together, the supervisee and qualified supervisor will want to complete the taxonomy of deliberate practice activities in psychotherapy, or a similar tool that assesses areas for growth and targets practice skills that are just beyond the supervisee's current ability. In the Goodyear and Rossmanier expertise development model, there is a helpful discussion of competence and expertise. The development of competence through normative skills includes professional and personal characteristics, trainee conceptual skills, and trainee relationships and technical skills. Moving from normative goals or competence, the supervisee identifies targeted individualized goals whereby development of expertise, or what one might call mastery, is addressed by developing a plan that focuses on improving the practice skills just beyond the supervisee's ability, or what Scott Miller calls stretch goals. It is at the intersection of normative goals and the individualized goals that FIT is essential for mastery by documenting efficacious therapeutic outcomes by clients on the SRS and ORS, and the supervisee's increased clinical expertise. It is important to build the normative foundational skills or competence upon which to develop expertise based on targeted individualized supervisee goals. Deliberate practice, as we will see, is the vehicle by which the competence to expertise bridge provides a sustainable pathway through one's journey in ongoing development of clinical expertise. After supervision and one is licensed, periodically one may want to seek a coach to further develop targeted skills which they want to add to their repertoire of therapy. Next, we will focus on the 4 pillars of deliberate practice. This is from Miller, Hubble, and Chow, 2020, in their latest book on deliberate practice. The coach assists the supervisee to develop an individualized learning plan. The learning plan is informed by performance feedback from the supervisee's client using the SRS and ORS instruments, along with videotapes that are done of sessions. As the data feedback is collected, the learning plan will be updated to include additional deliberate practice objectives. Components of the Therapeutic Supervisory Alliance include the goals of supervision that led to the individualized learning plan of the supervisee, the supervisory role of the qualified supervisor who manages the clinical supervision experience, and the development and oversight of the supervisee's goals through facilitation of deliberate practice exercises. Next, the application of methods and techniques in practice, and assessment of effective skills used by the supervisee determined by use of the SRS and ORS feedback from the supervisee's clients.
I want to discuss preparation for the therapy session, which I think is an important element of clinical supervision. However, in my own graduate education in counseling and social work, this was not discussed in our coursework. But I consider this element of our therapeutic work the artistic piece of what we do, and it's grounded in a client-centered focus, which are the common core factors we'll be discussing. I've synthesized several ideas to provide a framework for therapists as they think about preparation or therapy sessions. I call this stage of therapy the Crucible of Connection. The Crucible of Connection is that juncture where the therapist focuses on the client and working with the client toward successful outcomes in therapy. There are several concerns you might discuss in supervision. For instance, the use of self in practice. The use of self in practice is an important part of our work. However, again, that wasn't included in the education I had towards the graduate degrees, counseling and social work. However, the use of self in practice is an important technique and set of skills one can learn during the supervision sessions. How does the client and therapist interact? How does the therapist set a therapeutic alliance with the client, which is one of the common core factors? Those kinds of issues and others relating to self and practice, I think, are important as part of your discussions. Also, this concept of intuition, which I think is a very important element, particularly with online kinds of work as well these days, where intuition, by the way, I will define as the intention to partner with the client to reach the partner's goals, and imagination, where you attempt to experience the client's worldview, like walking in the client's shoes, as we used to say. In a sense, you're trying to capture the client's way of being in the world and how the client responds to interactions within the environment, the broader environment, both in relationships with others and their experience of the world generally. Also, the use of the common core factors we'll discuss is really the art of social work and how I look at the art in science. The science is like the therapeutic, evidence-based kinds of methods that we see in techniques. The art has to do with person-centered grounding, where one works with developing the therapeutic alliance, for instance, which is a critical foundation on which one engages in therapy. And along those lines, becoming aware of the client's experience of learning pathways. Are they auditory learners? Are they kinesthetic learners? Are they visual learners? Or do they experience a mix of those learning pathways in terms of how they gain and anchor information that they're learning? Very important, particularly when you're giving assignments for homework or when you're using what I consider the use of the client's metaphors. That's another element I think that's critical, is the use of the client's metaphors in therapy. How do they talk about their experience of the world? And if you're able to kind of place yourself in their space, what does that look like? What does it feel like? How does one experience what is going on around them? Those are important reflections, I think, as we work with a range of different clients with many different experiences of life, and how those may impact how one puts together the therapeutic plan and the partnership in which the therapist and client establish, which is again the use of self in practice, in getting to meeting the client and reaching the end result of the therapy. We will continue discussing this now.
Preparation for the therapy session, or what we might call the Crucible of Connection. This is a time for self-awareness to focus on the session. The therapist may want to concentrate on intuition that involves the use of intention to assist the client in attainment of desired results, and imagination where one empathically steps into the shoes of the client. During the few minutes that preparation takes, it may be helpful to become aware of centering one's focus on the impending session, attending to personal professional boundaries, interpersonal sounding, going within to begin to focus on what the session will be about, attending to the client's essence, putting on the therapist's face, which is a critical part in success with therapy in terms of how we present to clients, in terms of our enthusiasm for their being successful in their endeavor. Of course, the emotional empathic connection, listening and responding, being very aware of the active listening skills which are required, particularly in all of the sessions, and most importantly during the initial sessions with the client in establishing the therapeutic alliance. And then other ideas here that might be of help are trying to attend to what the preferred learning pathways are of your client. Do they respond better with auditory, visual, or kinesthetic methods? That could be critical in the outcome of the client's success, as well as engaging the client by using their own personal metaphors. The ecological, person and environment centered practice is grounded in common core factors. The core factors serve as the foundation upon which other elements of therapy take place. It is the first step in the therapeutic process with a client. This is the stage where both the art and science of therapy are fused into a holistic framework. The art of therapy begins prior to the beginning of the session with the client. It is there that the therapist focuses on intuition that includes intention and imagination about the client's situation, taking a moment to center on the intention to assist the client to attain the desired therapy goals. Intention mindfully locates the therapist in the here and now. Next, the therapist envisions what it is like to empathically walk in the client's shoes. Like an artist who is about to begin painting, this moment focuses on imagination, setting the mood for the therapeutic encounter. The common core factors intersect with the art that includes intuition and the science of therapy. There are three factors here for the purpose of our discussion. Under interpersonal factors, in collaboration with the client, is the central concept of developing rapport with the client, which is initially important for any success in therapy. The experience of empathy has one imagining walking in the client's shoes, experiencing how the client feels for the client to review the situation being described. The Therapeutic Alliance includes demonstrating positive regard, encouraging client congruency and genuineness, being present in the here and now, and the development of an expectation within the client that will lead to accomplishment of therapeutic goals. In addition, establishing the structure of the therapeutic moment allows a sense of routine that will take place each time the therapist and client meets. It is important to focus on the subject that allows for the flow of the client's work. The establishment of therapeutic rituals that punctuate and celebrate important progress in reaching the client's goals is an important way to anchor the client's therapeutic insight, learning, and success. Working with the client's expectation may have a significant impact on therapeutic success for the client. Such spiritual factors as recovery of meaning and development of hope are fluid elements as we work through the therapeutic process. The use of mindfulness practice, whereby the client focuses on the here and now, provides positive coping strategies and refocusing from rumination of past events or anxiety about future events to the present moment, which opens the path to significant therapeutic work. Having established the therapeutic alliance, the therapist engages the client in an exploration of the current situation. This involves listening mindfully to the client's story and making mental notations of key events throughout the client's life. It is within this space that the therapeutic goals and objectives develop, and these goals and objectives are mutually agreed upon between the client and therapist. In stepping back to review the client's situation and areas of concern, The therapist begins to develop an approach that will incorporate psychotherapy methods and techniques that are suited to the client's needs. In the past, much of the work of clinical supervision was focused on methods and techniques, the very science of our profession. The focus on case reviews without inquiring from the clients themselves about their experience or success in reaching goals seemed to be the norm. In our discussion today, we will demonstrate how a fusion of the art and science of psychotherapy complement each other and lead to positive client outcomes. Deliberate practice involves many elements associated with positive outcomes in therapy. The purpose of this discussion is to examine how the qualified supervisor and supervisee engage in deliberate practice. First, the supervisee reviews the feedback-informed treatment documents and understands how to administer them during the therapy session. In each session, the therapist will begin with the ORS overviewing the past week, and at the end of the session, the SRS includes the client's feedback about the session. The qualified supervisor and supervisee will review the feedback from the client and identify skills that need to be practiced during the deliberate practice exercises. This discussion will include an examination of the supervisee's concerns and recognition of improvement in the targeted skills of deliberate practice that have been selected in the Taxonomy of Deliberate Practice Activities in Psychotherapy as the stretch goals. The stretch goals will always include the top 3 current activities that the supervisee will work on. However, only one of the activities is worked on at a time. As part of the deliberate practice engagements, the qualified supervisor provides feedback regarding the skill acquisition and competency and mastery level of the supervisee. With each iteration of deliberate practice, the qualified supervisor will attempt to identify the skill level beyond the supervisee's current ability. In the ensuing discussion, the supervisor will work with the supervisee to visualize the competency and mastery level that will be attained during the iteration of deliberate practice. At that point, in the 3 stretch goals that are listed, the supervisee will move to the next goal area and practice the skill listed. The mastery level attained by the supervisee will be reflected in the ORS and SRS feedback from the client. Trauma-informed care principles include 6 person-centered engagement strategies. First, safety, physically and psychological safety. This is demonstrated most effectively in development of the Therapeutic Alliance and mindfulness practices used by the client and the therapist, setting a mood of safety for the client to talk about whatever their concerns are. Number 2, trustworthiness and transparency. Decisions are made with transparency and building and maintaining trust. This has to do with active listening, collaboration, congruence, building on the therapeutic alliance. 3, peer support. Individuals with shared experiences are integrated into the organization and viewed as integral to the service delivery. Extra therapeutic factors. When I was an associate professor at a university, I was supervising interns in field placements. And in one of the placements, the intern and I decided to work on forgiveness and self-forgiveness approaches. And so there was an order in which we went through the process where first people talk about who it is that they want to focus on forgiving or self-forgiveness, depending on what it was. Then they would do 3 mandala images to depict the past, present, and future sense of where they were with this particular individual or themselves. And then at that point, there would be a discussion and leading to an unsent letter to the party that the person was wanting to work on forgiveness with. In this one situation, the client was working with his father, who he hadn't seen in years, and he grew up somewhere in the Midwest. And in the middle image that the person drew, there was a house with kind of a dark cloud over it and a horse in the front of the house facing to the right of the person looking at the picture. And so when asked what this meant, he said that when he was around 16, he told his father he wanted to be an equestrian Olympic competitor, and his father said there was no chance of him ever doing that because he didn't even know how to ride a horse. So this kind of set in motion his angst through life in terms of what to do. And the last picture he had drawn showed him standing looking at the moon, stars, and a big question mark, which was his sort of take at his current moment of trying to sense meaning and purpose in his life. So in the letter he wrote to his father, he was supposed to write it, and then the next week there was going to be a Gestalt-like experience where he would use an empty chair to process that. However, in this case, the extra therapeutic factor was the father called him out of the blue and said to him, "I want you to come home and take the place over. I've been diagnosed with liver cancer and I have less than a year to live." In the process of that discussion, the client directly reconciled with his father rather than having to do the empty chair unsent letter exercise in the following week's experience. So it's unclear as the kind of extra therapeutic factors that may enter into therapy, but these synchronicity events, as Jung would say, emerge a lot of times in therapy and really enhance the outcomes for clients, which are out of the control of the therapist, but can be easily inserted into the therapy process, leading towards the goals of the client. Number 4, collaboration and mutuality. Power differences leveled to support shared decision-making are an important aspect of this therapeutic alliance, as we talked about from the beginning, and certainly that is one of the elements that fits into this. Certainly the genuineness of the therapist and the client, the expectation of hope and listening are other elements that fit into this trauma-informed care, person-centered approach. 5, empowerment and choice. Patients and staff strengths are recognized, built on, and validated. This includes belief in resilience and the ability to heal from trauma. Again, this client expectancy of a positive outcome and placebo sense of where things are going with the therapeutic work, also the sense of hope, discovery of meaning in the present moment, and congruence between the past, present, and looking towards future experience, along with collaboration and active listening on the part of the therapist. 6, cultural, historical, and gender issues, biases and stereotypes in historical trauma are recognized and discussed. Having entered into the empathically into the client's shoes, the therapist begins to work with the issues brought forth by the client, utilizing positive regard of the client, active listening, genuineness on the part of the feelings of the client and the therapist, hope, discovery of meaning in the here and now, and collaboration. Trauma-informed care principles are very much involved with the work with clients, particularly now during the era of COVID. Nationally, we've experienced a trauma all of us have had some part of. Some of us have had more severe experiences, either with COVID ourselves, the loss of family members, friends, relatives, and the implications of trauma in our work now, I think, are much more focused than perhaps in past periods. Fusion of psychotherapy elements. Here we enter the crucible of connection in preparation for the session just before starting a session with the client. This inward focus, whereby one arranges therapeutic furniture for the session, begins the process of work with the client on a particular day. The preparation time may only take 3 to 5 minutes, with checking in with ourselves, embracing our intuition as we acknowledge our intention to assist the client in attaining desired results of therapy, and imagining empathically walking in the client's shoes. This intra-personal sounding includes attending to personal boundaries, focusing on the client's essence, metaphorically experience the client's perspective from the client's shoes, and putting on the therapist's face. Next, in the outward focus of your work, you will begin by greeting the client. Moving into the session, one grounds oneself in the artistic space of the common factors. Begin by re-engaging the therapeutic alliance, including positive regard, congruence, and genuineness as you situate yourself empathically in the client's shoes. In the introduction to the session, revisit the sense of the client's expectation to accomplish therapeutic goals. Then invite the client to respond to the ORS questions over the past week and assist the client in discovering meaning for this week's work. Briefly invite the client to focus for a minute in mindfulness ritual before proceeding with the session. Note the session structure you have arranged, the use of ritual in session from the ORS to the SRS, and openness to extra therapeutic factors which may impact the work of the current session would be your main areas of focus. Where appropriate, use trauma-informed care principles in the foundation of the work you do in the session. In the next period, include the science of psychotherapy using your individually suited methods and techniques for therapeutic work. The art and science come together when the Therapeutic Alliance becomes the vehicle in which the art meshes with the science of creatively chosen methods and techniques. The session ends with the completion of the SRS. Deliberate practice ensues after the session ends in work with a qualified supervisor or coach. It is here where you work on your stretch goals on the one targeted area you are currently practicing. In the next session of this CE, we will provide some role-play examples of deliberate practice utilizing the ORS and SRS.
Hey, George, welcome back in again. How are you doing today?
Doing well. I'm looking forward to our session today.
All right. It's good to see you again. And so I'm excited to see what you've had the opportunity to put together for me. I know we started to talk about the taxonomy of deliberate practice activities, or the TDPA, and how that works hand in hand to help us begin to kind of mold and identify our stretch goals that we're going to start working towards. So here's see that, but I wanted to do just a quick kind of overview again, beginning with the TDPA and looking at those five domains of deliberate practice, where we have the structure, the actual structure of the session, the hope and expectancy there, the working alliance, both between you and the client, various client factors, and then also incredibly important, which we tend to kind of forget or sometimes disregard, are the therapist factors as well, too. All right. What were you able to kind of put together when we kind of parted ways last week?
Okay, so I went out and I reflected this week and completed the TDPA. So in the first section, it looks at structures of the structure of the therapeutic experience. Kind of review what we have here. There's activities listed discretely in terms of what the targets are, what my current rating is in terms of my expertise, my competency or mastery of the area, and then ranking the top 3 that would be appropriate for the stretch goal that we will discuss at the end. So in the structure section, I came upon 2 of the stretch goals right away. The first is how to close a session, which I ranked around 3 in terms of the stretch goals. And often there's an abrupt end to my sessions because I run out of time. And so the SRS provides a seamless structure in which one assesses the session and points to the homework or in-between session plans for the week. It's a nice way to close the therapeutic hour with the client, and I find that to be something that I want to work more on because it will help punctuate the end of the session for me, which I've had difficulty over the years including in a seamless way. And then, as you see, there's a number of other listings. How do you formally elicit detailed, nuanced feedback? That I do pretty well with, but how do you integrate the use of feedback measures into your way of thinking? I've not used the feedback measures before, and I'm really excited about the ORS and the SRS in terms of how they help structure the therapeutic time together. I didn't use these because of not having familiarity with them, but I believe that this really helps in terms of and in clinical supervision as well, because it helps structure how one is relating to the client. And so there's several other structure related goals that we had here. And then we move into what's called the hope and expectancy elements of practice. And I selected as my third stretch goal, A on this list here, how do you inform them about what to expect from one session to the next? And again, I think that the 2 feedback-informed treatment elements help. How to inform the client about what to expect. So the ORS structures the beginning of the session with a review of the past week's experience associated with what is being discussed in the sessions, and hopefully including the homework. And then the session rating scale, or the SRS, punctuates the end of the session, establishes clarity of the client's work, and points to homework connecting this session to the next. I haven't been particularly good in the past with this as well, so I believe that the SRS is really a wonderful instrument, not only to track the client's impressions of how things are going in the sessions, but also to structure it in a way that leads to a nice kind of ending of the session, looking toward what will go on in the next week between sessions. A number of other hope and expectancy elements here, which I think I do pretty well with the others as I've been in practice. although I think the ORS and SRS will tell us a little more as we go on in time by doing this weekly. And then there's the Therapeutic Alliance elements with the client, which, how to establish a goal consensus. These, again, I thought I did fairly well with without going into great detail on these because of the time factor here. And then the last part, which is called client factors. Actually, there's one more after client factors. This, again, were elements of things that I had done fairly well, I thought, with the clients in terms of my abilities. And then the therapist's use of self in practice. This is an important element, I think, that sometimes we overlook in clinical supervision as well, trying to get a sense of the therapist's use of self and recognizing how their various ways of looking at things, their sense of humor, how this all with other kinds of elements fit into the whole picture of practice, clinical practice specifically. And so there are some good outlines here of what questions one might want to reflect on. How do I manage negative feelings towards the client? These kinds of elements, which over the years, I think I've fared fairly well in developing those skills, at least in the present time of my awareness. And then reaching finally the end product of the TDPA, the stretch goals. So I've discretely listed 3 of those here. And so, John, I guess what we can talk about here is, one, as I go through these, thinking about as I present this, is this the proper order that we should do this in, or would you suggest a rearrangement based on how things flow? So I'll read through these and then I'll elicit your input on this overall direction. Under hope and expectancy, how do you inform clients what to expect from one session to the next? So over here, in terms of the SMART goal, the script will begin each session welcoming the client, reviewing the work in the past session, which is the ORS, engaging the client in discussion about what to work on in this session, and briefly restate what you will work on in the session, using the ORS measure at the beginning of the session and the SRS certainly at the end. So that would be my first stretch goal. The second is under structure, how to integrate use of fit measures into practice. Practice explaining each measure, administer the measure over a 3-week period. So in other words, I'm going to do deliberate practice over a 3-week period with delivering and presenting the method, both in session and out, and assessing the response with the supervisor of the meaning of the scores given by the client. And again, using the FIT tools, the SRS and ORS. The third stretch goal is how to close the session, developing a script to segue into the closure, practice transition phrases, administer the SRS instrument, and clearly outline the homework direct practice assignment for client. So this is kind of where I'm thinking of my first 3 stretch goals.
George, first I have to say, very nice job. I'm very impressed with what you've put together here. Thank you for taking the time to go through this and then also to share it with me. In addition to that, I like that you've identified these different domains, or rather I should say probably categories within the different domains that really overlap a little bit or are interwoven together in terms of their connectedness within the session. And looking at this, both hope and expectancy, structure and then structure, I first get the sense that the primary area where you want to work is really going to be in the structure. And my one little bit of feedback here, which is in no way criticism, but I think if we are going to inform the client what's next from session to session, we have to have complete understanding of what we are going to try to deliver to that client in the session. Mm-hmm. So my recommendation here would actually be to take what you've identified as your second stretch goal and actually move that up to your first stretch goal. Okay. All of these are developing scripts. I think a lot of this can probably be actually incorporated into different elements of one script.
Well,
right?
That really makes a lot of sense too, because I've added to my engagement of clients the ORS and SRS, and it would be best for me to have a handle on how those go in terms of presenting them, but also the implications of those for practice in session, because they seem to help in terms of structuring what one does with the client in a very positive way. And it's something one can expect from session to session. The client can understand that that's what's going on.
Right. And additionally to that, one of our best friends, whether it be in our day-to-day lives, whether it be in treating mental illness, is going to be routine. Oftentimes we utilize the therapeutic session to kind of model what, healthy relationships, what healthy boundaries look like. And we can also kind of utilize that here to demonstrate what a healthy routine looks like and how that can actually help to make somebody feel a little bit more at ease. And so if every time your client is coming into your office, sitting down, they know they're going to begin with the one assessment and they know that it's time to start wrapping up at the end of the assessment, I think that does worlds for them in terms of just, feeling a little bit better and a little bit more control in the session. And on the back end, maybe not what your client likely is not as aware about, but it's how much more in control it's going to help you to feel at the session, right? Allowing some of that natural anxiety on the therapist part to come on back and help you out.
Well, that makes sense. That really seems to flow well. I like that direction. I think it's doable, and I'm looking forward, as we do these first takes on stretch goals, to have those behind me. I think this is very helpful, and you and I have already begun to work with the ORS and SRS in terms of practice with that. And so our video that we'll do in the next couple of weeks, I'll include in this the CE as a sidebar here in terms of how that might look in working with a client.
Very good. Yeah, I think moving forward, let's just bump number 2 up to number 1. Let's start the process on that. You and I will continue to work on both your delivery and assessment of the assessments, the SRS and the ORS, and we'll kind of take it from there. Does that sound okay?
Yeah, I think that that is good. So we can just proceed from here then. I'll look forward to continue working with you on this.
Absolutely. All right. Well, hey, that works for now. As always, if anything comes up, please don't hesitate to give me a call.
Okay, and we'll meet next week again. Thank you.
Thank you. All right, George. So this is the point where we're going to go ahead and shift the SRS and the ORS. What I'd like for us to do is go ahead and run through this right now with me being your client and you being the therapist delivering both of those measures. Would you be comfortable with that?
Yes, that sounds good. Mm-hmm.
Okay.
Okay, so we're in a session and we've gotten through the ice breaking of, can we see each other clearly? Can we hear each other? The location. And now I'm moving into doing the ORS with my client. As we begin our sessions, we will each week do the outcome rating scale, which is a review of your last week experiences kind of combined together. And you'll decide based on these experiences whether it's a 10, which means the best you could have experienced for the week around a particular item, or a 0, which would be the worst. And then you can also use decimal points if you would like a 2.5 or a 6.7. Let's look at the first scale here. You'll notice there are the 4 items we had talked about over the past couple of weeks. Looking back over the last week, including today, help me understand how you have been feeling by rating how well you have done in the following areas of your life, where marks to the left represent low levels and marks to the right indicate high levels. Now, you're going to be giving me a number, and I'll record that, so you don't have to worry about marking it because we're viewing it here on screen. The 4 items will start with the individually. So in terms of your individual items, and these include mental health, physical health, emotional and spiritual health and well-being. What number would you assign to your sense of individually this week?
I think I'm floating probably right around like a 6.
Okay. And looking at the interpersonal items, that is your relationship with family, how would you mark that this week? What kind of score would you give?
I'd probably say like around an 8. I'm fortunate to have some very good family, a very good relationship with my wife, and I have several friends who I can count on during difficult times.
So, this is important from our talks last week about the social support being most important, because a lot of times these are people we can kind of share our concerns with to help reduce the stress that we experience. And then in the social domain, or as they say, socially, the areas of work, school, and friendships, what kind of a score would you give that this week?
Yeah, so I think with this one, probably like a 6.5, maybe even a 7. I think work continues to be my primary stressor. I mean, yeah, outside of all the little things in life, but then I think, like I said, I mean, I've got a good group of friends, and then it just kind of comes back. I think it's probably just a little bit of burnout from work at this point that's really kind of anchoring me down. But other than that, life is pretty good.
When you share with friends, in terms of this work element, do you have people at work you can talk with to kind of de-stress as well, or any of those friends part of that group, or are you all your friends are separate from work completely?
The majority of my friends are separate from work. I have a few people at work, kind of closer colleagues, but I haven't really had the time or the opportunity to really, spend any time with them outside of work or really kind of develop the relationships beyond that professional level, if you will.
While you're at work, do you sometimes decompress with them over something that you've all experienced together?
Oh, majorly.
Okay.
Yeah.
Because that's a good outlet. That's what I was trying to look for as another possibility. And then moving to the overall, your general sense of well-being this week, what would you assign to that?
Yeah, I mean a 7. I mean it's not going to be a 10 since obviously I feel a need to be here sitting with you. No offense. I think the idea is how we can kind of increase that overall score to be a little bit higher.
Okay. Overall, things are kind of in the mid to upper range in terms of how you're feeling generally from what you were saying, the outcome rating scale, which we will utilize as we talk today about where we left off from the last session. So now we're going to cut and I will do the SRS. So JJ, we've now come to the end of our session this time. And as we do that, it's helpful for us to each week revisit the session rating scale to sense how we've done today working with each other. And again, the scale is the same. 0, for instance, in the relationship area, as far as our work, you didn't feel heard or understood and respected, or on the 10 end, you felt understood and respected. So there's sort of the 0 to 10 again, numbers is talked about and practice. Item 1 is the relationship between the two of us. Did you feel heard, understood, and respected this week? What number would you give that?
I think probably like a 10.
Okay, and that's helpful. Thank you. Then under the goals and topics, could we talk about what was relevant to you this week?
Yeah, we did. I would have to say maybe like a 8.5 or a 9 on that one because I feel like we probably could have gone a little bit more into the concrete goals that we've been working on, but at the same time, I mean I recognize that it's all geared towards that.
Okay, and then in terms of my approach or method, what did we do that would work for you today in terms of my approach?
I'm very appreciative of just feeling that I am being heard, having an outlet to vent to and get all this off my chest. It's not that I don't have a strong support network, but at the same time, I am concerned about burdening my wife, and she has her own stress and her own stressors, and wanting to take care of myself and also lead by example and not be afraid to ask for help when I need it. So I think just the simple act of creating that space for us to do that is very important to me, which I appreciate. So once again, I think it's a very good fit, and it's certainly helping me to progress. So again, I'd have to probably give it a 10.
Okay, and then overall score, taking everything into account, what would you say is your overall score for today's session?
I think 9.5.
Okay, so as you go forth this week, based on what we talked about, what would you want to do a little different this week? I talk about when you return next week on the ORS.
So with the ORS, I think the ORS is very good at kind of helping me conceptualize where I'm at, how the week has gone, and where everything's fitting in. I think what I'd appreciate from you is maybe cueing me a little bit more to relate that back to the goals that you and I have set together. And I know that might be a little bit more concrete than we have been in the past, but I think going ahead and making sure that we are gearing the conversation consistently towards those goals is going to be important for me, especially in terms of me not running off and little side tangents in my mind.
Well, based on what we've been working on, you've been improving on the ability to vent and to somewhat compartmentalize work when you're with friends and home, and you seem to be developing certain competence in being able to do that. And it seemed like in terms of your feedback from last week, we talked again about your family and your social support are a real solid part of that. And then this issue of burnout at work. So looking more at self-care kinds of things that you might do would be perhaps something to add. Like this week, you might do one or two things for yourself. Does anything come to mind that you might do for yourself this week where you could kind of derive some sort of sense of R&R, so to speak, from it?
Well, I think probably, trying to focus a little bit more on exercise, where we kind of get out, I can walk the dog, listen to some music, and just kind of have a little bit of me time. Or, if she okay with it, I could also invite my wife to join us so that we could have a little start carving that out as maybe some additional quality time.
That is really good. That's two things, and that makes sense. Having the personal space is important, but also in terms of the relationship with the wife. Those two are plenty to be working on, probably for several weeks, but trying to think consciously about what one thing you might do in both areas, and then see how that, looking back next week, comes together. So yeah. Why don't I leave you with that, and we will resume next week when we meet and see how it goes for you in terms of your experience.
Yeah, that sounds good.
Okay. So basically then, we're at the end of the ORS and SRS, and so just a little conversation before we leave this video. As the client, even though this was kind of quick and fast, what was your experience of our exchange this week?
So
with the ORS and SRS.
So as the I am right, and so I'm acutely aware of how you can continue to utilize your skills of active listening. These general more so generalized rapport building skills that we're familiar with, which I think are very important, even when we administer measures, because all too often we fall into these kind of ruts, especially with measurement based care, where it becomes very cold, just like, hey, fill this out real quick, thank you, moving on.
Yes.
What is unique and why it fits the deliberate practice is that is that it is measurement based care, but it is actually gauging the client versus how often it's that these other measurements that we utilize, although important, are oftentimes disengaging, right?
Yes. And that's really what I like, is that it really puts the rubber to the road, so to speak, in terms of, from reviewing the previous week and the session, really ties together more closely what our goals and objectives are and how we're getting to them or not. And so I think the numbers really do have significance when you begin to look at these over, say, 20 or 40 sessions, if there's that many. But as your sessions go along, seeing how this changes, because incidents will happen and change the person's experience for a few weeks sometimes.
And what you end up doing, right, is so you data points ultimately, right, after a number of sessions. You have your immediate snapshot, and let's just say on the ORS or the SRS for that matter, that I scored very, very low. Which was abnormal. This cues you as the clinician that there has been some type of significant shift within the client, and calls for follow-up and further action and potential safety assessment and so on. And you make another great point with the more so longitudinal time. Now we're tracking how the client's progressing. And we both know that generally speaking, recovery from any form of mental illness is not going to be a truly linear path. Like, it kind of looks more so like one of those stock market scales, more or less. We're going to have the ups and the downs, but we get to then say, hey, do we have an overall trend up or do we have an overall trend down? And after you've been working with a client for a while, this opens the door to have that discussion, right? To say, here's what your progress looks like, conversations. This is all this data that you have given me. What do you think of this? Is this reflective of how you're feeling right now? And that brings us to another big point, that a lot of times we even within our own lives, we don't give credit to the smaller steps, right? We don't give credit to the small victories. We are in a culture of a need and a want for immediate gratification. And so sometimes being able to show, hey, you were here, and now whether it be 15 weeks, 40 weeks later, you're all the way up here. That can help to satisfy some of that and reduce some of that sometimes perceived almost like frustration or stuck points, if you will, for excuse me for pulling from the CPT crowd, but feeling stuck.
And what I like, the general connection, is that the two instruments are kind of like a thread that keep you focused on where things are going. Because I think sometimes it's easy to get distracted in terms of whatever's going on and miss a couple important points that are
that will help the client improve. And so the constant feedback, I think, is helpful. And so anyway, I guess
and I think having a routine, having consistency to the session, just like you were talking about in your other stretch goals, with having that structure, right?
Yes. Okay. Well, also, I like the idea that the client's homework is really the client doing deliberate practice as well. It's an interesting kind of parallel dynamic, I think, in this whole process, because the ORS is kind of the weekly touching base about how that went. It either goes or it doesn't, but it's the same with my practicing how to do the ORS and SRS. The more elegant I can do it, the more likely the progress will continue and we can move on to the next level. So I think, I like this idea that we're all doing deliberate practice in some fashion during this process. The supervisors, the supervisee, and the clients. And so I like that.
And George, let's not forget about the very, very important kind of ethical point of having that professional boundary of not working harder than your client.
Yes.
What this does, this really puts you right alongside your client, right? You're not pulling them along with you or anything like that, which is a common pitfall that we fall into sometimes. It's really saying, hey, here's the conversation, this is the topic, here are the goals, what do you want to do? Okay, let's go with that. And it breaks it down very nicely.
Well, and the measure then indicates who's doing what. So it even brings more of an opportunity to discuss that issue when for 3 weeks nothing's happening. And so
Right.
you have to hopefully it won't be 3 weeks before you catch it, but then you have to ask the question like you do, who's working harder here? Am I doing too much work and you're not giving you space to do more? Anyway, that's a good point. I think it helps, and it's critical for the therapist